Okay, so good morning, everyone. I'm Olya Kolaris. I'm the pediatric nephrologist here, and I'm here to welcome you on behalf of Dr. Leonard, who's unable to join us this morning, and then our Pediatric Grand Rounds Committee and Department of Pediatrics. So welcome. Hopefully, everybody had a good Thanksgiving break. And today we are moving on with the Grand Rounds for December and pre-holiday season. Initially, I would like to acknowledge the Stanford University Land Acknowledgement. We recognize that Stanford sits on the ancestral land of the Mokina Ohlone tribe, and just want to recognize that. A couple of reminders. You will see on the left that there's a text code to use to acknowledge your presence today so that you are eligible for CME credit. And then as well, feel free to enter your evaluations and suggestions for the future, and also respond with some comments for MOC credit. Moving on, I will have Dr. Maas present today's speaker, who we are very happy to host from University of Colorado. But before that, I'd like to introduce the upcoming pediatric grand rounds. Next week, we will have Dr. David Rakoff here from Stanford University talking about the long-term impact of environmental factors. And then later on, we will have Dr. David Chan, again, talking about the ethics, also from Stanford School of Medicine. And now I will give the floor to Dr. Maas to present our speakers today.
Well, thank you very much, and welcome everyone in the audience. And I see we have a good crowd online as well. And so it's my great pleasure to introduce Dr. Phil Zeitler. He's professor of pediatrics at University of Colorado and Colorado Children's Hospital. He is the section head of endocrinology. He's also the clinical director of the Clinical Translational Research Center there. Phil has many accolades in addition to his many hundreds of papers. Some of those include being past president for the Pediatric Endocrine Society, as well as being the current editor-in-chief for the journal Pediatric Diabetes. Phil has trained many pediatric endocrinologists and researchers, and also be remiss not to say that his son is a Stanford graduate as well. So we've had a lovely time. He gave a great endocrine grand rounds talk earlier this week. And so Phil, welcome. And we really look forward to your talk on type 2 diabetes. So thank you.
Great, David. Thank you so much. It's so weird to sort of gradually be moving out of the fully Zoom sort of world and finally start having some people in the room. We've been talking a lot about how do we encourage more people to come back, and it's really hard because many pediatric departments like you and like us have all these different sites, and it's really quite a lot to expect people to come from their clinic in Sunnyvale to just come here for 1 hour and then fight traffic to go back. So I think this is something, and I think it seems to be particularly for pediatric departments have done this kind of spreading of their clinical time. And I think we need to think hard about how we're going to make sure that people continue to interact. Anyway, so we're going to talk about youth-onset type 2 diabetes. And what I want to do is give you a sense of the unique aspects of type 2 in kids, clinical, social, sort of public health aspects of this disorder. These are my disclosures. So I want to start by reminding people about the pathophysiology of diabetes. And because, is that going to have a, yeah, okay. Because most pediatric providers are really used to type 1 diabetes being the most common kind of diabetes. Some of these aspects of the underlying pathophysiology of diabetes have not really been well appreciated. And I'll point that out in a moment. But now that we're dealing more with type 2 diabetes, we really need to try to understand the much more complex situation. So this is a very well-known figure that looks at the relationship among normal glycemic individuals. Now, these are adults, but the data are the same in kids. That shows the relationship between insulin sensitivity and insulin secretion. And this hyperbolic relationship between them is really a critical feature of glucose regulation. In type 1 diabetes, we don't think about this very much because the drastic decrease in insulin secretion sort of hides the relationship with insulin sensitivity, right? It's the insulin secretion deficit is so fundamental to the type 1 diabetes that this relationship is kind of camouflaged, although it's becoming more an area of interest in type 1 diabetes also. But it's important to recognize that you can maintain normal glycemia anywhere along the spectrum of insulin sensitivity or resistance, however you want to think about it, as long as the amount of insulin you are making is sufficient to compensate for whatever loss of responsiveness you have. So I think, at least our generation, we were taught, oh, type 2 diabetes is a disorder of insulin resistance. But it's actually not, because insulin resistance isn't causing any trouble here, right? As long as you make enough insulin, which suggests that really the problem is a problem of compensating for whatever that degree of sensitivity is. So if we now look at what happens in the development of diabetes, type 2 diabetes, and these are pediatric data, but they're pretty much exactly the same in adults. What we see is that as you go from normal glucose tolerance to impaired glucose tolerance to type 2 diabetes, there is worsening of insulin sensitivity over time, but not really very much, particularly when you just go in early stages of dysglycemia. However, if you look at what happens to insulin secretion in response to a glucose challenge, you see that here's your first phase insulin secretion and followed by a second phase. And what we see is as you develop impaired glucose tolerance, you start to lose that first phase of insulin secretion. Second phase is initially retained. But then when you develop type 2 diabetes, really what is happening is loss of insulin secretion, right? So it's not worsening of insulin sensitivity. It's actually loss of insulin secretion that determines diabetes. So if you go back to that hyperbolic relationship between insulin sensitivity and insulin secretion, what you see is that you can maintain normal glucose tolerance anywhere along this curve as long as you stay on the curve and the amount of insulin that you make is appropriate. But if your beta cell function starts to deteriorate, you start to fall off of this curve, initially with sort of high normal glucose, followed by impaired glucose tolerance, and eventually type 2 diabetes when beta cell function is deteriorating. So the bottom line here is that type 2 diabetes, just like type 1 diabetes, is a beta cell disease, right? And that's really something that people have recognized increasingly over the last 20 years. There is something called the disposition index, which is a mathematical way of identifying the relationship between the amount of secretion that's occurring and the amount of resistance that's present. And if one looks at the disposition index, what we see is that the disposition index nicely correlates with the degree of dysglycemia. So again, this is a problem of insulin secretion. Before we go further, this is an issue that comes up all the time. And so I want to talk about what's the deal with prediabetes. So in order to talk about what prediabetes is, we actually need to talk about what is diabetes, right? Does anybody have a sense of how diabetes was defined initially? Anybody know? That's a symptom. But how do you know if you have diabetes, right? What's the number? How was, we say, oh, a blood sugar of 200 after a glucose tolerance test is diabetes. Where does it come from? I mean, wasn't handed down on stone tablets, right? So it's really quite important to remember this when you're thinking about diabetes. So essentially, diabetes was defined by increased risk for microvascular complication, and particularly retinopathy. So essentially, the way diabetes was defined, how the number got chosen, was epidemiologic studies like this that showed that as your blood sugar goes up, your risk for retinopathy increases. And somebody said, oh, it looks like it's right around here. So that's diabetes, right? And it's really important to remember that diabetes was defined as risk for complications. There's nothing magic about 200 as a number. Okay, sorry. In terms of hemoglobin A1C, you can see the same relationship. So what you can see with hemoglobin A1C is that after the hemoglobin A1C gets to a certain point, you start to see a rise in prevalence of occurrence of retinopathy. Again, what's the number? Well, it's continuous, right? There's nothing a real threshold. I mean, at some point you don't get any, but it's continuous. And somebody said, okay, well, when you get to 6.5, there's enough of an increase that this seems to be meaningful. Okay, so again, this is all defined by risk for complications. There's a lot of argument about A1C as whether this is a good definition for diabetes. And the reality is that A1C, as you can see, is at least as predictive of the development of retinopathy. It's not a continuum necessarily. It's a continuum in here, but there's a A1C below which there's no risk for retinopathy. And it is also true that the various tests, fasting glucose, 2-hour glucose, and A1C do not always correlate, but they're all related to increased risk for retinopathy, which is the definition of diabetes. Okay, so what's prediabetes? Well, prediabetes was defined by the ADA as a test result, glucose tolerance test, A1C, that predicts progression to diabetes, okay? So again, based on epidemiologic data, that if you have a certain test result, your risk for developing diabetes subsequently is increased, okay? Again, not magically handed down on tablets. These are results of epidemiologic studies suggesting this relationship. So why define prediabetes? Well, in adults, there are strong data that support increased risk for diabetes. There are also strong data that demonstrate that treatment can prevent progression to diabetes. And so therefore, there is value in defining prediabetes in adults. The criteria for prediabetes, i.e. the glucose values that predict progression, have never been validated in kids. So you get an A1C of 5.8, 5.9 is, oh, the kid has prediabetes. We don't know that. We know nothing about the values that actually predict progression to diabetes, which is the definition of prediabetes. So this casts questions on whether or not prediabetes is a valid phenomenon in kids. It may be, but we don't know how to define it. We are extrapolating adult norms. And for reasons I will show you in a few minutes, extrapolations of adult norms may not be appropriate in kids, particularly during puberty. And I'll show you why. And essentially, prediabetes is a second-degree extrapolation. So we're extrapolating adult data to predict progression to a state that we are extrapolating. We don't even know the definition of diabetes in kids. We assume that a blood sugar of 200 means the same thing. And it makes sense, but we don't know that. There's never been epidemiologic studies that demonstrate this relationship. So prediabetes concept is a double extrapolation. Secondly, we can't even reliably test for dysglycemia in kids. So a lot of people will say, oh, the glucose tolerance test is the gold standard. Well, is it? So this is a study that took kids and did glucose tolerance tests 3 weeks apart, and then just looked at what the initial result was, yes, no, diabetes, followed by the second test. And what we see here, yes, a fair amount of correlation, but also a lot of kids who had diabetes in the first test don't have it on the second, and vice versa. And it turns out the concordance is only about 29%. So not a great gold standard when you think about it. How about A1C? This is a study that we did at our safety net hospital in Denver. Huge numbers of patients, 15,000, 17,000 patients with that are seen in that system. A large number of obese patients, and we looked at whether or not A1C predicted progression to diabetes within 2 years. And what we see is, yes, kind of. Those patients who have a prediabetes A1C but less than 6%, very little progression to diabetes. So the adult definition of prediabetes doesn't work in these patients. If you get above 6%, it's better, but it's still less than 20% of those kids are actually progressing to diabetes. So again, casting question on the definition of prediabetes in kids. And then finally, we had the opportunity to look at some data from a large cohort of healthy kids. It's actually from the Healthy study. And this study was a bit of a failure. They were attempting to go into schools and change food and activity and everything, and it didn't have any impact. But they did thousands of glucose tolerance tests in 6th and 8th grade. And they had a control, they had everybody in the school. So they had lots of non-obese individuals in this, and they were getting glucose tolerance tests. And so we were able to look at these results. So these are A1C results, just because they're a bit cleaner to look at. And what we see, what you see actually is that 2% of non-obese healthy kids had an A1C in the prediabetes range during puberty. Now, 2%, that's not so bad, right? Standard deviation, that's about what you'd expect in a distribution. But if you look at it by ethnicity, 7% of African-American kids had a prediabetes A1C. So again, raises questions about the definition of prediabetes in adolescents. And it may very well be that there's a physiologic increase in glucose during puberty, just like there is during pregnancy. This may be important for promoting growth. So what do we do about prediabetes? We still do want to understand if kids are at increasing risk for diabetes, right? So what's an approach that might be reasonable? So the other thing, which I will again show you in a minute, is the prevalence of type 2 diabetes, even in kids at the highest risk, is extremely low. So Bayes' theorem tells us, right, that if a disorder is extremely low, your chance of getting a false positive from any test is often going to exceed the likelihood of identifying that disorder. So this is a problem here. And this is a very interesting example of how Bayes' theorem needs to be taken into account when you're doing screening for this. So how could you use this? Given the low prevalence of undiagnosed diabetes, the value of screening remains unclear. And I'll show you some additional data in a minute, again, from Healthy. If the A1C is greater than 6.5%, you have to take it seriously. This may be diabetes. It may not be. Oftentimes, the next A1C a week later is 6.1%. A1C greater than 6%, they're probably at high risk for progression, about 15%. You can argue whether that's high or not, but it's something. And if the A1C is greater than 5.7 to 6%, this is probably not useful. These curves are right shifted in kids. A1C is a little bit higher, particularly during puberty. And as I again will show you in a moment, there's a very high regression back to normal glucose tolerance in these individuals. Okay, so a bit of a rant on prediabetes. We get a lot of referrals for prediabetes. And the fact is, I don't even know what it is. And I don't know what it means. Okay, so let's turn now to type 2 diabetes in kids. So I want to focus really on the unique aspects of type 2 diabetes. We've already talked about the underlying physiology. It's the same in kids as in adults. But there are some very unique aspects. And this is one of them. In adults, there are about 1.5 million new cases of diabetes a year in adults. In kids, the best estimate is about 5,000 new cases a year across the US. So this is a rare disorder. It's much less likely to develop type 2 diabetes. And there's a study, we got it? Okay. Yeah. There's a study that's being put together now that will include measures of social, psychological stress as kids are heading towards puberty. We're back. Okay. Okay, so these are data from the SEARCH study. This is a population study representative of the US. And what we see is prior to age 10, it's almost exclusively type 1 diabetes, irrespective of what ancestry group you come from. Yeah, there's some type 2 diabetes, there always has been. There's reports of kids with type 2 diabetes going back to the 40s and 50s. But when you get to the age of 10, this sort of, we've come a long way during COVID, but then this magic thing happens that after age 10, the situation changes substantially, so that among certain ancestry groups, there is a predominance of type 2 diabetes. Now, obviously, I'm facetious about magic. There's nothing magic about 10. What is it? It's puberty, right? So we keep on getting this sense that puberty is related to diabetes in adolescence. It appears during puberty. There's a sex difference that occurs that you don't see in adults. There is a shift in A1Cs during puberty. So what's this all about? Oh, by the way, I think, yeah, I always mean to move this. This is the estimate for how many kids in the United States have type 2 diabetes. About 40,000. This is a rare disorder. What do these kids look like? These are data from the Today study. They're the same in any study that you look at, really. The average age of onset is about 14. It's about a year earlier in girls than boys. Another suggestion that this is puberty related. They're very, very obese. The typical child with type 2 diabetes has a BMI that's substantially greater than the typical adult with type 2 diabetes. They are pubertal, mostly late pubertal. There's the female predominance, predominantly minority. although this is a little bit flawed because the kids were chosen a bit to represent those groups, and very tightly related to family history. That's no surprise. We see that in adults. But here's something quite interesting. 30% of kids with early onset of diabetes were born to a pregnancy complicated by diabetes. Socially challenged, less than 40% are living with both parents. The majority are living with the mother, and somewhere around 10% are actually not living with either biological parent. Parental education is low, and this is from 2010, so the numbers are probably a little different. But 40% of these families were making less than $25,000 a year. Very few making more than that. So this is a population that is socially, educationally challenged with severe obesity. The prevalence of undiagnosed, unlike in adults, half of cases of adult type 2 diabetes are undiagnosed. You go out into the state, whatever, I'm sure you guys have health fairs. You go there and you're going to identify large numbers of cases of diabetes. The prevalence of undiagnosed diabetes in kids is extremely low. These are data from NHANES. This is a CDC study that goes out and puts kids in a van and draws blood on them, offers them candy. Anyway, diabetes was less than 1% in these populations. This is the healthy study again. I told you this went into schools. The nice thing is that these were high-risk schools, greater than 50% minority, greater than 50% eligible for free or reduced lunch. So exactly the population that we see getting type 2 diabetes. They had glucose tolerance tests in 6th and 8th grade. And what did they find? Almost no diabetes. So unlike adults, there is not a big pool of undiagnosed diabetes that's out there, which suggests that there is not a long prodrome, right? If there was a long prodrome before kids became presenting clinically, then you would find them in these kind of studies. So it suggests that the biology of progression is very different. Did you have a question? Okay, that's a fair point, that they would be picked up clinically, except that it's not that common for kids to be identified with diabetes on routine testing. They mostly present. There's some, because people look more than they used to, but this truly, and I don't think we're going to have time today, but we have data that really demonstrates that they sort of, boom. So again, different. Adults with type 2 diabetes, just for years, their A1C is kind of gradually rising, and eventually they develop clinical disease. But we just don't see this. This is really sort of catastrophic. It happens very rapidly. And we even have kids where we had previous A1Cs and they were all fine like 6 months ago, and now all of a sudden they've got an A1C of 9%. Okay, I mentioned that there's a very high rate of regression back to normal. This is a study, it's getting kind of old now, but other studies have shown something similar. This is from Yale, and they followed 100 kids, no intervention. So these were just natural history. And of that 100 kids, about 30% of them had impaired glucose tolerance. That's actually quite a typical number for adolescents. About 30% of at-risk kids will have impaired glucose tolerance. So then what happened? So about 30% of them progressed, in some studies lower than that. But what's striking is substantial regression back to normal with no intervention. And in some studies, that's as high as 60%. I actually think it's probably closer to 60%. The vast majority of these kids will, in fact, redevelop normal glucose tolerance. Why is that happening? It's probably happening because of this. So this is looking at insulin resistance, so upside down, if you will. Resistance is worse as you go up in girls and boys. And what we see is that as you go from Tanner 1 to Tanner 3, 4, there is a worsening of insulin resistance that then improves. And there's a lot of controversy about what age this actually returns to what you'd expect for an adult, et cetera. But clearly this pattern of worsening and then improvement likely relates to this return of glucose tolerance. So if you think of that curve, so if you have restrained beta cell function and your sensitivity worsens, you're going to fall off that curve, right? Now you may get diabetes, or you may just get impaired glucose tolerance. But if the beta cell function is not too bad and the sensitivity gets better again, you get back on the curve once the resistance is over, just like gestational diabetes. It's exactly what happens during gestational diabetes. People who are at risk develop diabetes. After the pregnancy is over, many of them will return to normal, but that's a predictor of future diabetes. And some will continue to have diabetes. So, in summary, despite the striking increases over the last 30 years, youth-onset type 2 diabetes remains a rare disorder. There are strong risk factors that include early life exposures, including gestational obesity and diabetes, that have not been identified in adults. There's a gender disparity in adolescents not seen in adults. Youth onset is tightly linked to the physiologic changes of puberty. There is a high rate of spontaneous glycemic improvement with exit from puberty. These patients are generally more racially and socioeconomically challenged than adults. And there is also a high prevalence of fatty liver, hypertriglyceridemia, sleep disturbances, depression, etc., and a very high prevalence of renal hyperfiltration that appears to be predictive of rapid decrease in eGFR subsequently. Okay, so I want to turn to a study called the Today Study. This is a study that I was associated with for 21 years. It's just ending in April of this year. And this was a study looking at three different treatment approaches to type 2 diabetes in kids. That's actually not that important. What I want to talk about is the shape of the outcome curves, which is the point I want to make here. So these are the data. And so the blue line is kids who got metformin only. The green line are kids who got metformin plus a very intensive lifestyle intervention. And the red line are kids who got metformin plus a drug called rosiglitazone or Avandia. You probably know Avandia from the lawyers' advertisements on TV about if you were exposed to Avandia, contact us, you might be eligible for compensation. And there's an interesting story behind it, although there's probably nothing wrong with Avandia. But what I want to point out really is if keep in mind what this curve looks like, right? So a relatively rapid decrease in maintenance of glycemic control. So as they go down, these are patients losing glycemic control according to the study definition. And then kind of a plateauing as you get out about 5 years. The rate of loss of glycemic control with metformin was unexpected. And if the reason it was unexpected can be seen in this figure. So if you look at the Today Study, this is the metformin arm, at 36 months, 50% of the patients had lost glycemic control. You'll have to take my word for it. It's not adherence. Yes, adherence is a problem in kids, but this was a study and their adherence was better than you might expect. If you compare this to the same treatment in adults from a study called ADOPT, what we see is that at 36 months, only 10% of the adults had lost glycemic control. So there's a more rapid loss of glycemic control in the kids than in adults. Now, why is this? If you look at the kids who lose glycemic control in red versus the kids who didn't lose glycemic control in blue, what we see is that this measure of insulin secretion, called the insulinogenic index, is falling rapidly in the kids who lose control. So this is beta cell problem. And if you look at the disposition index, same thing, rapid loss of insulin secretion relative to the demand. Putting together a whole bunch of different studies, what we see is that the metformin failure rate in kids is about 3 times higher than adults. The metformin plus rosiglitazone failure rate is about 3 times higher in kids than in adults. Changes in insulin sensitivity over time are actually worse in adults than in kids, but there is a much more rapid change in beta cell function, a negative change in beta cell function in kids than you see in adults. So what today taught us was that unlike in adults, metformin monotherapy is actually inadequate for half of kids with type 2 diabetes. And actually, if you look at just African American kids, 50% of them had lost control by 12 months on metformin. The role of intensive lifestyle interventions is uncertain. As you saw in that figure, it wasn't particularly exciting. But most importantly, youth with type 2 diabetes have progressive loss of beta cell function that is rapid relative to adults and is irrespective of treatment. So why is this happening? I'm going to turn to another study called RISE, which has been a very important study in understanding the pathophysiology of type 2 diabetes in kids. So RISE was asking the question whether in participants who had impaired glucose tolerance or very early, recently sort of identified diabetes, whether you can preserve or improve beta cell function through interventions. And the honest way, the interventions don't matter very much because what matters is the physiology looking at adults and kids. And the most important thing about RISE is that RISE offers us the first and only to date direct comparison head-to-head of youth and adults with dysglycemia using identical protocols and identical treatments. The treatments were not all that exciting. Insulin versus metformin, essentially, very aggressive insulinization to take the stress off the beta cell. I'm not so excited about that for today's talk. Here's the study design. They had screening, a run-in. Then they underwent a intensive evaluation of insulin secretion and sensitivity. At baseline, they were treated. This was repeated at 12 months. They were then taken off their drug, and it was repeated again 3 months later. This is what the hypoglycemic clamp looks like. You take the individual, you give them a glucose bolus, get their blood sugar to 200. You then maintain that blood sugar of 200 with a dextrose infusion. And the amount of glucose you need to keep the blood sugar at 200 is a reflection of insulin sensitivity. So you can actually measure steady state insulin sensitivity after this is stabilized. Then you give, so this is what we found. Insulin sensitivity in the kids, substantially lower than in adults. Not a big surprise. We knew that kids generally require larger amounts of insulin to get them under control than in adults. So we were somewhat expecting this. Now, I told you that kids are generally more obese than the adults with type 2 diabetes. So maybe this is just because they're more obese. However, what you see here is across the spectrum of BMI as a surrogate of adiposity, insulin sensitivity in the kids is lower than it is in adults. So these kids are more insulin resistant than adults. That's why you see so much acanthosis in these kids. Okay, so then you give another glucose bolus, you get them up to 600, followed by an infusion of arginine. basically to maximally potentiate insulin secretion in these patients. And that gives you the opportunity to measure insulin secretion here, steady state, or in their maximum situation. So what do you find? Well, what you find is that the kids are making more insulin than adults, no matter how you measure it. No surprise, right? That curve. The more resistant you are, the more insulin you have to make, right? So maybe this is just because they're more resistant. However, if you actually look across the spectrum, these are the same thing, just log transformed. If you look across the spectrum of sensitivity, at any degree of sensitivity, kids are hyper secreting. They're hyper responsive to the underlying degree of insulin resistance. So, what do these tell us? These data show us that youth are more severely insulin resistant than comparably obese adults. At any level of insulin sensitivity, youth secrete proportionally more insulin than adults. And it is hypothesized that this beta cell hyperresponse represents a fundamental difference in the physiology of dysglycemia between youth and adults. And it may be that this difference in hyperresponsiveness could explain the more rapid rate of progression in kids, because at a certain point, secretory demand becomes a strain on the cell, and it may lead to more rapid loss of insulin secretory function. And there's a number of pieces of data that suggest that. Proinsulin, which is a marker of sort of misfolding of insulin, rises and is higher and rises before loss of glycemic control in the kids, suggesting that there's something about the endoplasmic reticulum stress, which is kind of a wastebasket. But this is a strain on these cells. Okay, one last series of slides looking at the differences in physiology. So this is just looking at the intervention that occurred in RISE. So, again, you gave these kids and adults an intervention and then looked to see if it had any effect on beta cell function. And in order to understand the slide I'm going to show you in a minute, we need to do a little cartoon. So here, okay. Here is the cohort at baseline. They have a certain insulin sensitivity and a certain beta cell response, right? And that cohort, two things can happen. They can stay right where they are. They could get better, either better beta cell response, improved insulin sensitivity, or a combination, or things could get worse. Worse beta cell secretion, worse insulin secretion, worsening of insulin sensitivity, or some combination. So going up or down from this curve is either a positive or a negative outcome. So here's the population at baseline. What we see is here's the adults, here's the kids. Right away, we see again what we've already talked about. The kids are more resistant. They're also on their own line. They don't have the same relationship between sensitivity and secretion. What happens to them over time? Here's the adults. What you see basically is they move back and forth on this line. It wasn't a remarkably effective intervention, but they basically stay on that line. What happened to the kids? Bam, negative result. Things got worse in these kids over time, where it wasn't happening in the adults. Now, the interventions didn't work, okay, didn't necessarily work in the adults either, but clearly this is a different trajectory than this. Again, supporting the idea that beta cell function is more rapidly deteriorating in kids. So within each treatment group in RISE, beta cell function worsened over time despite the intervention. 3 months after withdrawal of the intervention, beta cell dysfunction was worse than it was at baseline, whereas at least in the adults, it was the same as it was at baseline. So these results confirm that many aspects of pathophysiology in youth with type 2 diabetes are more severe and more rapidly progressive than in adults. There's two possible explanations. One is that, well, there may be others, but two I can think of. One is that developing diabetes during puberty is somehow a bad thing. And so there's something about that. The other one, which I prefer, is what I call the slowest gazelle in the herd. Basically, the individuals who get diabetes early are the ones at the greatest underlying risk, right? They're the ones whose beta cells can't compensate. They're the ones who, if the environment is appropriate, will develop diabetes. So no surprise, if you get diabetes early, you also have a more severe form of the disease. Otherwise, you wouldn't get it early. And we don't know. But my guess is that that's what we're seeing. That it's actually not getting the diabetes in puberty. It's who gets the diabetes during puberty that matters. So what? So how many people here would rather have type 1 diabetes than type 2? How many people would rather have type 2 than type 1? Come on, you got to vote, guys. So most people would rather have type 2, right? Yes, and that's what most families say. Oh God, no, I hope it's not type 1 because it's so hard. Okay, that's the wrong answer. And these are data looking at mortality in young onset, so onset prior to 30. Type 1 in red, type 2 in black, and we can see that the mortality rate is substantially higher in type 2 diabetes. And by 20 years, 20% of these individuals who got diabetes less than 30 years of age are dead. And that's not the case in adults. And it's mostly cardiovascular disease that's causing these deaths. And it's actually really bad to get it young. So this is standardized mortality ratio based on age of onset at various ages subsequently. And you can see right away, if you get diabetes, between 15 and 29, your peak standardized mortality ratio is quite a bit higher than if you develop it at any other date. And what this means is it's not just that you've had diabetes longer, it's actually worse. And again, I think this is the gazelle in the herd, the slowest gazelle in the herd problem. These are data from the Today study again that were published last year in the New England Journal, and it's just looking at the rate of development of complications. And this is hypertension. 70% of the kids have hypertension after 12 years. Not that surprising, 50% with dyslipidemia. Here is kidney disease. Almost 60% of these kids have diabetic kidney disease by the time they get to 12 years, and neuropathy. About 30% after 12 years. So substantial amounts of disease. And if you look at the incidence of any microvascular complication, what we see is that 80% of these kids will have at least one microvascular complication by the age of 12, by 12 years of duration. They started at 14. So these are now 27-year-olds with substantial diabetic complications and clustering of complications. So it's actually unusual to only have one. Quite common to have multiple complications. And more strikingly, lots of other events. You can say, okay, neuropathy, whatever. But 27-year-olds, arrhythmias, coronary artery disease, congestive heart failure, heart attacks, strokes, DVTs, end-stage kidney disease, severe neuropathy, blindness, macular edema, vitreous hemorrhage, and 6 deaths. Only 2 of which were not diabetes related. So 6 deaths among 699 kids who are average age of 27. So the lessons from all these trials. Progression of youth-onset type 2 diabetes is more rapid than in adults. Forget that, we didn't talk about that. Risk for complications in youth onset are high and will occur during the prime of life when these kids should be starting families, starting jobs, with serious public health implications. Youth onset is associated with high rates of other comorbidities of obesity and insulin resistance, and therefore treatment of youth with type 2 diabetes requires us to put aside our pediatric attitudes about, let's just give them a little medicine. We need to be treating them early and more aggressively than in adults. They're gonna live for a long time. They have rapid accumulation of problems, And this includes medications in combination to improve insulin resistance, slow the loss of glycemic controls, and decrease the risk for complications. Treatments should be personalized, ideally based on understandings of this unique physiology in these patients. And unlike in adults, type 2 diabetes in kids is not a primary care disease. This is a very complicated pathophysiology, high risk for poor outcome, and substantial socioeconomic challenges. And with that, I will stop and thank the people who actually do the work, and let me come and get wet in Palo Alto.
Thanks, Phil. And we've got a couple of questions that came in via Zoom. Anyone in the audience would like to ask a question? You're welcome. Maybe start with one from the audience here.
Across multiple generations. Do you think that this is like there is a genetic predisposition underlying the impact of socioeconomic, or do you think that we're seeing epigenetic changes from the socioeconomic stress?
It's a really great question. Before we moved to the new hospital, so this would have been early 2000, there was a talk given at Pediatric Grand Rounds in Denver entitled, "Is Trauma a Genetic Disease?" And they meant, physical trauma, because you do see clustering, right? So it's a really good question, and I don't think we know the answer. What is interesting is that you do see anticipation like you do in some genetic disorders where, grandma got it at 60 and the mom got it at 40 and now the kids got it at 15. Is that because our environment has gotten worse? Is that because their home situation has gotten worse and this contribution of stress is important? I don't think we know the answer, but it's a very good question. And we think of type 2 diabetes in kids as being a social disease. It's a canary that is reflecting much of what is going on in our society. And it's one of many, but it is clearly socially driven.
Thanks, Phil. A question from Zoom is from Daryl Wilson. Relative rate of type 1 and type 2 that you showed was from 2002 to 05. Has this changed over the last 20 years?
Yeah, it's a really good question, Daryl. And I keep meaning to update that slide. It's basically the same relationship. They've all risen. Depending on the ancestry group, the rate of rise of type 2 has been a bit higher than in type 1 diabetes. But yes, they're both rising. Type 2 is rising a bit faster, but the general relationship between them is more or less the same.
And another one from Zoom. Would you recommend not screening for type 2 diabetes, or how would you recommend we go about doing that?
Yes, I recommend not screening for type 2 diabetes. That is not a universal opinion, but I think when you screen for a very rare disorder, you're going to run into trouble. Now, it's important to distinguish between screening, which in my mind is going out to the 9 News Health Fair or whatever the equivalent is here, and just testing everybody, as opposed to case finding. If you have a kid in your practice who strong family history, exposed to gestational diabetes, has gained a whole lot of weight, that's case finding. And in my mind, that's justified. There was, in the 2000 ADA guidelines, they said, basically if you have one of these and one of those and one of those, you should screen. On the most recent guidelines, we backed off of that because there's no evidence to support that. But what it now says is, consider the risk factors and determine whether you think you should test this child based on the number of risk factors they have. It's kind of squishy, but I think that actually reflects the evidence. We actually don't know. The vast majority of high risk, family history, obesity will not have diabetes. So we don't know how to pick out the ones who will yet.
All right, and we are at 9 o'clock. So thank you all for joining online, and for those of you in person, thank you very much. And thank you, Phil. It was a wonderful talk, and Thank you for coming out and spending a couple of days with us. So, bye-bye.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.